Is sitting less and moving more associated with fewer adverse pregnancy outcomes? Which blood pressure medications are least likely to cause patients to stop treatment because of side effects? What's fueling the rise in hospital-owned health plans? And does it improve care or just consolidate markets? This and much more on today's JAMA Editor's Summary. Hello, and welcome to our listeners all around the world. Today is Friday, May 29th, 2026. I'm Dr. Linda Brubaker, JAMA Deputy Editor, sitting in for JAMA Editor-in-Chief, Dr. Kirsten Bibbins-Domingo. Today, I'm joined by Dr. Preeti Malani, another JAMA Deputy Editor. I'd like to start with some new evidence about activity patterns during pregnancy. Dr. Gibbs and colleagues conducted an observational cohort study of 470 pregnant individuals in 3 U.S. states to assess the relationship of activity and adverse pregnancy outcomes, which affect 1 in 5 pregnancies, with long-term consequences for both mother and child. These adverse outcomes include hypertensive disorders of pregnancy, gestational diabetes, preterm birth, and infants that are small for gestational age. Participants were enrolled at less than 13 weeks gestation, and physical activity was measured using an accelerometer worn on the thigh. The authors reported a clear take-home message: sitting less and moving more, even light intensity physical activity, might lower the risk for pregnancy complications. Specifically, they reported that sitting for 10 or more hours per day was associated with a higher risk of adverse pregnancy outcomes compared with sitting for 7 hours per day. And very high levels of light intensity physical activity was associated with half the risk of adverse pregnancy outcomes compared with a low level of light intensity physical activity. These patterns may be a practical prevention strategy.
Thanks, Linda. That's definitely practical. And although moderate to vigorous exercise can be tough to maintain, especially during late pregnancy, sitting less and walking around feels like something that can be sustained. Also this week, we have a study about blood pressure-lowering drugs and their side effects and discontinuation rates, a question that comes up daily in clinical practice. In fact, there are about 116 million people in the U.S. and an estimated 1.4 billion worldwide that have hypertension. This network meta-analysis included 716 double-blind randomized trials covering 5 major antihypertensive drug classes and their combinations, with nearly 160,000 participants included in total. These trials were considered short-term, with follow-up durations between 4 and 26 weeks. The authors, Dr. Wang and colleagues, focused on which drug classes and combinations were most likely to be stopped because of adverse side effects. They found that compared with placebo, calcium channel blockers alone or paired with ACE inhibitors or beta blockers paired with thiazide diuretics increased discontinuation rates by about 1 to 1.7%. In contrast, angiotensin receptor blocker or ARB-containing regimens, especially ARB monotherapy or ARB plus calcium channel blocker combinations, saw fewer dropouts than placebo. In addition to treatment discontinuation due to any adverse event, the authors also specifically considered dizziness, headache, edema, and cough. The key clinical message for patients and clinicians here is that certain blood pressure-lowering drugs and combinations are better tolerated than others. This information may help inform treatment decisions.
Preeti, that information could really help clinicians counsel patients when they start or intensify hypertension therapy. An editorial by JAMA Deputy Editor Dr. Mary McDermott and Dr. Purcell offers helpful clinical context and reminds readers to ask patients about side effects that may be associated with antihypertensive therapy, since adverse effects can impair adherence, which in turn may reduce the ability of these medications to prevent cardiovascular events.
Linda, let's turn to a research letter by Dr. Chen and colleagues. The authors conducted an observational study on the rise in provider-sponsored health plans, hospitals that also provide insurance product, so-called Payviders. The authors used American Hospital Association survey data from 2018 to 2023, which covered nearly 3,800 hospitals. During this time, the proportion of hospitals with their own health plans rose from 18% to 27%. Medical school-affiliated hospitals and nonprofit institutions were more likely to adopt this Payvider model. The long-term effects on costs, quality, and workforce are still uncertain, so continued monitoring is warranted.
Interesting, Preeti. That's certainly a trend worth watching. The related editor's note by Dr. Yu and JAMA Deputy Editor Dr. Joseph Ross emphasizes how these integrated models might improve care coordination and population health, but could lead to higher costs for out-of-network care and new pressures on clinicians. The authors stress the importance of monitoring the benefits and risks of these models.
Well, let's move on to viewpoints.
Dr. Daphne contributed a viewpoint that considers whether breaking up healthcare conglomerates is the right fix for high costs and market concentration. The author writes that a legislative bill like the proposed Break Up Big Medicine Act would be an overly blunt instrument. Instead, smarter antitrust enforcement and tackling the root incentives fueling consolidations might curb costs without collateral damage.
A thoughtful viewpoint by Professors Gostin and Eskridge assesses the Supreme Court's recent decision in Childs versus Salazar. Although the specific case related to conversion therapy for minors, the authors explain that the ruling places new constraints on state medical licensing authority, limiting viewpoint-specific bans on talk therapy while leaving room for regulation based on conduct, informed consent, and anti-fraud protections.
And there's a timely article from Dr. Hurtalendi and colleagues on the recent Hantavirus outbreak. The authors describe the ongoing outbreak and review several lessons for global health preparedness. Linda, estimates suggest by the year 2030, nearly 55 million U.S. adults will have hearing loss, including 35 million with mild hearing loss. In their Insights article, Dr. D'Souza and Swanepoel update readers about hearing aids for adults with typical mild to moderate hearing loss. This Insights article offers helpful information on counseling patients, when to refer a patient for audiometric evaluation, and special considerations about over-the-counter hearing aids.
There is a clinical review on the diagnosis and management of adult male hypogonadism, a clinical syndrome of signs and symptoms of testosterone deficiency. In this review, Dr. Anna Walt and colleagues provide a detailed summary of the pathophysiology, clinical presentation, diagnosis, and treatment of hypogonadism.
There's also a new JAMA Clinical Reviews podcast about cesarean delivery without labor on maternal request. Linda, you and Dr. Alpern discuss more on individual counseling, including potential risks and family planning for patients. And this was all based on a previously published Insights article.
Yes, Dr. Alpern and I had an opportunity to discuss some of the issues that come up during labor, delivery, and later in life. Individualized counseling is key for patients seeking a cesarean delivery by maternal request. Let's take a listen to what Dr. Alpern had to say.
It's important to take into account the individual's goals and also individual's risk factors. Just like we were just talking about a young person who wants to have many babies, who is thin and who has strong muscles and can recover better than somebody who's older individual who's, for example, only wants to have that one pregnancy. Maybe it was conceived with the help of in vitro fertilization or some assisted reproductive technologies, for example, and it is not planned to have more children. The risk-benefit ratio of planned vaginal delivery versus planned cesarean section are really different for these two scenarios.
The JAMA patient page this week covers head and neck cancers that involve the mouth, throat, nose, and salivary glands. HPV is now a leading cause of cancer in the U.S., especially for oropharyngeal cancers. This is a helpful resource for patients to learn more about the risk factors, treatment, and more for head and neck cancer.
And this week, like every week, there's a lot happening in health news. The JAMA Medical News team has a summary podcast that publishes every Friday and gives our listeners insights into the latest medical news. You can subscribe at jamamedicalnews.com or click on the link in this episode's show notes.
Well, that's a wrap for this week's JAMA Editor's Summary. Thanks, Preeti, and thanks to our listeners for tuning in to hear what's new at JAMA this week. These highlights were brought to you by Dr. Preeti Malani and me, Dr. Linda Brubaker. This episode was produced by Shelley Steffens and Dr. Krista Roberts at the JAMA Network. A link to this JAMA content can be found in this episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. And thank you for listening. This script was generated with assistance from AI tools, GPT 4.1 OpenAI, following an editor-developed prompt. The content has then been reviewed, edited, and approved by editorial staff.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.